So now, mid-cycle, ready to liberate the cell for the possibility of fertilization. LH surge triggers ovulation, actually weakens the tunica albuginea next to the Graafian follicle. It's weak enough so that the pressure inside breaks through the tunica. So this is the moment of ovulation. Fallopian tube standing by in the background, waiting to capture that liberated egg cell. A moment later, the liquor folliculi in the antrum jets out to form a cloud around the egg cell, and then in moments becomes tacky, called the super glue effect. A moment later, see how extensive it can be. The egg cell is just a little tiny right in here, but this maximizes the possibility of capture. Sticks onto the fallopian tube, and now goes inside as a captured egg cell. As a consequence of tearing open a spot in the ovary to liberate the cell, there's a hemorrhage. So you should know the post-ovulatory sequence. Initially, a little body of hemorrhage, the corpus hemorrhagicum. You can see this quite clearly on the surface. There's the most recent ovulation. You go to the interior, see how extensive it is. Each half showing the corpus hemorrhagicum. 2-3 tablespoons of blood in this hemorrhage, which is best known for how quickly it's lysed or dissolved away. From the tissue, you have lutein cells that will invade and dissolve. It becomes clear.
The hemorrhage, whatever.
Hemorrhagicum.
The hemorrhagicum.
Yeah, it's early. It's hard.
That's right after if there's not pregnancy, right?
After ovulation.
Right,
After,
this is just
that's after
at ovulation.
Okay.
Ovulation is somewhat violent to the ovary.
Right.
When you're actually tearing through the tissue with capillaries and vessels that will now have a spot bleed in that part of the ovary. So whichever one ovulates, then you'll get a corpus hemorrhagicum. All the others dissolve away. There's nothing like this at all. Right? So then it goes translucent and then condenses to the corpus luteum, the yellow body. Luteum is yellow in Latin. And then sooner, if there hasn't been fertilization, or much later, if there has been, this ultimately becomes a little scar tissue. Looks white. This one probably years older here. It shrinks down, so you get these little spots of scar tissue marking every ovulation in each ovary. So this is the corpus albicans, the white body. So post-ovulation, you got your hemorrhagicum, luteum, albicans. Sequence for post-ovulatory structures. And then, as I mentioned, all the others that were developing at the moment of ovulation, they become atretic, meaning to dissolve away. Nothing will ever mark that they ever existed. Only the one that ovulated gets a little bit of scar tissue behind. All right, so that's your sequence. Then the easily identified fallopian tube by its unusual interior. It's nice and tubular outside, even smooth muscle cells in the wall, but the interior is a mass of mucosal folds, coddling the egg cell in between the folds. So if you look real close, right up in here, that little dot is an egg cell. See the size of it compared to what it's being conducted through in the fallopian tube. So when we magnify on this 150 times more, a little shriveled up there, but there's the egg cell, and it's traveling in between the folds. You get a sense of how luxuriant they are, scanning inside the fallopian tube, where the folds now are tremendous with the little egg cell in between. Yes, and the shadows being conducted along. Need you to know the two special characteristics that you find in the wall of the fallopian tubes. Take a little area like this, magnify another 500 times, and you see ciliogenesis. Looks like a lawn on the surface of the cells. You need to use the word ciliogenesis to indicate that this is cyclical growth. Parallels the ovarian cycle. And then it makes sense that you're looking at the motility for the egg cell. These gently wave down towards the uterus. I always say that spermatozoa has its flagella. Well, you can think of this corresponding to the motility structure for the egg cell, cilia. And then you know some are not ciliated. You get little microvilli on the surface, not cilia at all. So years ago, like a peg into a lawn, we call them peg cells, little pegs. You should know that these are nutritive. They produce a nutritive secretion, nourishes the egg cell and the spermatozoa, which stay alive longer and more active, thereby encouraging the possibility of fertilization. The cells join into one. That's special for the fallopian tubes. Ciliogenesis, nutritive egg cells, working together to maximize the possibility of fertilization, perpetuation of the species. And then the uterine histology starts here with the mass of smooth muscle, myometrium, compared to the delicate endometrium, this glistening layer on the interior. So we like to do a little block section in the wall, just a little block, and see the difference in the histology. Where now you have the myometrium, very thick and dense, swirling smooth muscle fibers. And then the endometrium looks very soft, here to here, fluffy looking, much less dense. So this is endometrium. Next week you need to know the sublayers. If it's vascular, which you're seeing here, that's the basale, the basal layer that's always there. Above it, uterine glands, little glandular pockets, which tells you this is the functional layer, the functionality, constantly changing for the functionality, or ultimately the menses layer of the endometrium with basale functionale. Sublayers. All right. And then if I mention this one, I'll say blood vessels are dominant in this layer. They're usually not as obvious as this. This is the best specimen. Some you don't see quite as many as this. And that's just an ectopic, tubal, estimate to adaptability that these are delivered successfully every day, particularly outside this country. In this country, usually these are terminated, very dangerous, but every so often they'll be delivered. And even more unusual, an abdominal or pelvic pregnancy. Just need a surgical delivery at term. No way that they can get out of the pelvis without surgery. Ovarian cyst. It's hyper-enlarged graphene that refuses to go away. Larger and larger. All right, on to gross anatomy, nervous system. Start with the meninges, the coverings, brain and spinal cord. That underneath the meninges, dura, arachnoid, and then you're just seeing the pia, the glistening layer that you see right there. Transparent, very delicate. And then you have the soft tissue in the cranial vault, Bren, now brain. You should divide it into three parts. Cerebrum, 85% of the Bren, the brain. Behind cerebellum, 13%. And then underneath, you'll see the brain stem, up from the foramen magnum, the remaining 2% of the mass of tissue. I'd like you to have those three defined areas of the brain. And then you see the cerebrum, left hemisphere, right hemisphere, longitudinal fissure separating them. You look down in the fissure, you see the great bridge, corpus callosum, connects them together. And then behind, a completely different looking cerebellum. Even has a little extra lobe down the middle. The vermis. And if you ever hear firmus and neuro, talking cerebellum, right down the middle. And then you see the cerebrum with its convolutions, the gyri, the gyrations, and the little sulcus, sulci, folded to decrease the surface necessary to accommodate all this tissue. And then all these names and numbers that you'll find with the gyri and the sulci, neuroanatomy terminology. And then you see a different texture for the cerebellum, much tighter, more compressed. You then define the four lobes of the cerebrum, easily done with the frontal lobe up front, parietal over the top, occipital in back, and then temporal along the sides. Four lobes of the cerebrum. See the difference for the cerebellum in terms of the gyri, much more compressed. Sometimes over folia. That's okay, but just